लाइव चालू झालं.
जय हो बम्बई धाम की है बम्बई नगरिया तू देख बबुआ की है बम्बई नगरिया.
Hi, good morning everybody.
Good morning.
Can you guys see us, hear us?
Yeah, we can hear you.
Yes, may I know whom I am talking to?
This is Dev Palajani, Praful. And with
hello sir, how are you? Good morning to you.
Good morning.
Good morning to you.
With me is Dr. Manish Parekh.
It's so nice to...
Yeah. And you have got a very elaborate and very distinguished panelists here from all over the country. And we're very happy to be listening to you and seeing your case. Can you please tell us something about your case, please?
Yes, good morning. Yes, we are very, at the outset, let me thank Dr. Srinivas and his team and the other course directors for giving us this opportunity to perform live. This is the second time we are performing live, as you must be aware. Just before we get started with this case and what we have for you, we'll give you an update on what happened last year. They say that during live transmissions, you do get more complications than you would otherwise get in your lab. We had a very pristinely performed case last year, the RSOV device closure. Everything seemed so nice, and just pre-discharge, our man developed a minor PR prolongation, and which actually went unnoticed, and we discharged him. And 4 days later, he represented with a complete heart block and a syncope. Thankfully, this responded to high-dose steroids. This is a complication that we normally see with perimembranous VSDs, and this gentleman responded to steroids. This is the first time in the world literature that such a thing has happened, and we have actually reported it, and it's getting published in Journal of Invasive Cardiology. So we are just hoping that today we do not meet with any further complications. And we have today, after that session that you have had in controversies in STEMI intervention, we have really a controversial case with us. And before Dr. Milind Phadke, my colleague here, gives you the update and lets you know about the case, let me quickly introduce the team. With me, there is Dr. Charan Lanjewar here, Dr. Prasanna Nyayadish. Next to him is Dr. Milind Phadke, who will present the case. Then we have Arvind Kamli and his team, who is a technician of the lab. Then we have a team of paramedical staff, the sisters, Alka Patil. Last year she was called Alka Jadhav. And here it is, the whole bunch of residents who have been up all night. Again, we cannot forget, especially in STEMI interventions, we cannot forget somebody like our anesthesia team. We have always been there with us. We have Dr. Madhu and her team. Okay, over to you, Milind.
Good morning, everybody. So I'll just give you a brief update about the case. Now we have with us a 25-year-old male who has a history of tobacco use.
We can't hear you.
With a history of an acute
Can you
just a second.
Can you bring the mic right to her?
Mic right to you.
Hello, can you hear me now?
Hello. Yeah, you can't hear him, then I'll give you the case.
Yeah, okay.
Yeah, this is
Praful,
can you see the slide up there?
Praful, your mic is okay. I think the other mic probably is not working.
Okay. Okay, so here we have a young gentleman, 25-year-old male, whose only risk factor is tobacco use. He's a tobacco chewer, who presented with an acute extensive anterior wall on the 1st of August. Today we are on the 4th. He presented on the 1st of August with a STEMI and presented at a peripheral community hospital. We heard Rupa Salvan talk about that most of them don't even get thrombolysis in our country. That's exactly what happened with this gentleman. In spite of a hyperacute anterior MI, he didn't get thrombolysis. And he presented to us on the 2nd, 24 hours later. He was pain-free by then, but he was in Phillips class 2, evolved anterior MI on the ECG. Well, we got him onto heparin. That's about all that he received. We received low molecular weight heparin, and we took him up last evening for an angiogram. And if you can show the angiogram, so that, can you see the angiogram now?
Yeah.
Yeah, so that was the, no, this is today morning, this is just today morning shot. So what happened is that yesterday's angiogram, which will just start now. No, not this. This is with the guide catheter that we have taken this morning. Okay, this is it. Just stop that. Okay. Can you see that? This gentleman has a thrombus sitting in the proximal LAD. Yeah, next. Play that. Yeah, so this is the PA cranial shot. You can see the thrombus extends right down till the first septal perforator. And as far as disease is concerned, he's got just a minor plaque. Go ahead. Play all the films. So last evening, we actually got him onto a 2B3A inhibitor. And because we were going upstream with a 2B3A inhibitor, we've given him tirofiban overnight. And he's received about 14 hours of tirofiban. And that's the kind of an LV. Could you play that LV shot again? And keep it on recycle mode. Yeah, so this LV, looking at this LV, most of us would think that you can see a little dyskinetic apex and a huge anterior MI. So we were really wondering what's the point of intervening on this guy. So last night, we have a very good cardiac MR with us also. So we got a cardiac MR done. And in that cardiac MR, there is a huge viability there in this entire segment. So we are left with this, and you want to take up, how do we go about it? Dr. Pelajani with the moderators and with the other guys there?
I think, Praful, I'll put it to my co-chairman and the other panelists to understand from them.
Yeah, we are 72. Just to summarize, we have a young...
Yeah, go ahead.
We have a young 25-year-old with tobacco chewing as the only risk factor who has come with a thrombotic, who is now presented 3 days later. We are with 3 days since the MI. He's got a huge anterior MI with a huge thrombus chunk sitting there with a good TIMI 2 flow, I would say, down the artery. And you saw the picture. Okay, can you see? We'll just before they opine, we'll show you the guiding shots today.
Praful, any history of cocaine in this guy? Young fellow, 25 years?
No, he's just a tobacco chewer.
Tobacco. In the tobacco, he did not sniff some cocaine, right? Manish,
possibly, I don't know. He's a gutka guy. He's a good...
Praful, I would like to have the opinion from my colleagues here. Manish is sitting right next to me. Manish, here is a guy who's 25 years. He is already infarcted about 3 days back. Now you see a totally dyskinetic apex. You see a TIMI 3 flow in the LAD. What would you do at this stage? He's already 3 days old.
Yeah, I think that, because of his age, you have to give this patient the benefit of the doubt. I think what Praful has done is absolutely appropriate. He has defined that the anterior wall is viable, that there is justification to revascularizing him, that there will be recruitment of myocardium with treatment of this vessel, think the most aggressive thing needs to be done for this patient, which is optimal both antiplatelet therapy and antithrombotic therapy. I think, Prafula, as far as giving tirofiban 12 hours prior, I think we used to do that in the U.S. We don't any longer because we can give intracoronary abscissumab and then extract thrombus. I find that to be as good, but I think that this is a very nice way of proceeding in the situation you're in. I think that this patient probably, if you had the option of ticagrelor, this is the ideal ticagrelor patient or prasugrel patient. Clearly, he should be on aspirin.
Right.
And then, in our laboratory, we would use bivalirudin. If that's not an option here because of cost, unfractionated heparin would be fine. My procedure here would be very simple, which is to use a 6 or 7 French guide to wire it. And before I touch this is to do thrombectomy. I would use an export catheter. I would do multiple passes, maximize my extraction. And then if I was comfortable direct stenting this, I would direct stent this. I don't like direct stenting often, but I think that pre-dilating oftentimes causes no reflow. I would try to maximize the vessel size with my angulations and views, give nitroglycerin to vasodilate, put 1 stent in, deploy at nominal pressures, and try to be done without post-dilating. That would be my strategy.
Praful,
exactly.
What has been the experience or the data?
Is there anybody who is against? Is there anybody who is against intervention here before we proceed? Because I
will have my own.
Are we going to do?
Praful, I will have my own reservation at this stage to intervene. The reason is he's already 3 days old infarct. He has already got a dyskinetic segment. He is totally asymptomatic.
Yeah.
Third, to put an export catheter and try to aspirate the thrombus, which is already 3 days old. I don't know. One would be really successful in taking out the thrombus, which is 3 days old. Mukund, you have any thoughts on this?
So we have two.
So we have actually,
even I was actually very wary about it. We all know in thrombotic situations, it's going to be so difficult what we take a call. But if the consensus is that we should intervene, then I wouldn't mind intervening. But even I am actually quite reserved about trying to do something here, whether we are really going to do good or how much is the potential to harm him as well.
Let's have an opinion of Dr. Mukund Deshpande from Nagpur.
Praful, good morning. Mukund Deshpande here from Nagpur.
Yeah, good morning, Mukund. Tell me, what do you think?
Yeah, Praful, see, this is already a 72-hour or maybe more old MI. And what do you suggest? Maybe just only trying to only put an export catheter and take out the clot. Only that.
Okay, and if we are not successful, then do we stent it at all?
No, I don't.
Or we come out?
No. I don't think.
What if we worsen him?
No,
after
actually,
the export?
There is a high likelihood. I have had a patient of like this who actually was in Ahmedabad, and he was also a similar kind of fellow, 21-year-old student of engineering. He had an acute MI, and we just aspirated his thrombus, and that was it. All that hibernating or whatever myocardium improved.
Okay, so now we've decided as a
suppose
group
if I
here,
suggest to you that you, and a guy like this who is not symptomatic, you just put the patient on aspirin, clopidogrel or prasugrel or whatever you want to give, along with a low molecular weight heparin, wheel in the cath lab at a time in case he gets symptomatic, because he is in KEM hospital and where emergency services are available all 24 hours. Or otherwise, if he remains asymptomatic, do an angiogram after 1 week and see what happens.
Sir.
Well, I'm good with that too. I would actually, sir, I was thinking, because after all, I'm your student, sir. I was also thinking last night.
You are already having a less than TIMI3 flow already. So do we want to persist with that?
I think he has got some comments to make.
And this is Dr. Mukherjee from Hyderabad, Dr. Praful. Actually,
yes, Dr. Mukherjee.
In this patient, the MRI is showing some viable myocardium, and I think we should go ahead, and we should have gone ahead with the procedure last night. The second thing that I want to make is MRI is not all that sensitive to pick up the viable myocardium always. Even we have seen in some patients,
in terms of
in patients in whom initially MRI has shown that it is non-viable or there is no residual myocardium also, these patients also down the line they are developing symptoms. When we repeat the MRI, they are showing some evidence of reversibility. So in your patient, I think we should go ahead with the procedure. We should have gone ahead with the procedure last night when you have got the MRI with you, I think so.
No, actually last night or otherwise, I am just hoping that more pharmacotherapy will make him a better candidate. We surely will pre-discharge, get him in again, is what I would say. Now, in terms of, see, actually because we were supposed to have done an acute STEMI intervention, the whole night our residents were waiting for a STEMI to come along, and neither did a STEMI or an NSTEMI come through the night yesterday. So I am actually very wary about trying to intervene on this guy. And like what as Dr. Pelajani says, since he is here in our hospital environs, where we have a 24-hour service in terms of anybody within the hospital deteriorating, we are able to move to the lab in 30 minutes. So we would do that. Watchful waiting is what we would do with this gentleman rather than intervene at this time. However, in terms of the use, we were actually, the plan what Manish suggested was very much here on table. We are with the new generation of an export catheter, but whether we would succeed only with export, underlying there is no residual plaque there, no residual stenosis, and the TIMI flow as such is as good as what one would get after a stent. It's TIMI 2.
Praful, there are two things. One is the flow. TIMI, it's less than TIMI 3, right? Second,
yeah, you show that. Can you see that shot again? Show the
second point is you have already up.
Yeah, see, look at this shot again and again. So we were all set here for the intervention, but after having seen not much improvement since last night till now, as also that that just post thrombus, there is a minor plaque, which is all, and the artery actually distally looks better. Unless he gets evidence for rethrombosis or he hemodynamically deteriorates or anything on those lines, we'll bring him back. Again, the thrombus will possibly involve the first septal if we cause some shift of the thrombus and get some right bundle branch blocks, etc. We are also in terms of direct stenting.
M-guard you can use.
This is a very unusual case. First of all, the age of the patient is very young. He's 26 years. He has got just one localized
more likely
lesion.
To be prothrombotic.
And looks to be something like, I was wondering whether there was an auto dissection there. I don't know. I can't see it properly from here. But maybe you can appreciate it better there. Do you see some line of dissection somewhere there, auto dissection?
Oh yeah, now that you say it, sir, it's all the way down going into the septal perforator. You mean the medial edge, yeah?
I got the feeling
there is a sliver of a...
There was an auto dissection in the other view also. And the third thing is a case which is challenging.
There is some stain which is
challenging where
on the undersurface of the LAD. Yeah. In this shot you can see that.
The challenging Praful in the way that the opinions will be divided. Some people will say, do you do it? Some people say, don't do it. And I'll tell you, I've come across many times such a situation, and I've decided to wait. And now I realize why my number of cases are less than other people's.
No, sir. That's not the point. I will wait over here. But in the interest of the situation, since we have live transmission going on, talking about thrombus aspiration, just about 2 weeks ago, we had a acute thrombosis in the lab in the sense that an embolization into the LAD following a mitral valvuloplasty procedure just 2 weeks ago. Can I show that to you?
Yeah.
Because here consensus of my lab also seems that we will not intervene.
What is the consensus? Please say it again. Not to do it?
My consensus in my lab is also not to intervene, sir.
Yeah, I don't know. I think that probably is the most sensible thing to do, because doing and not doing is not going to harm the patient, and waiting for a week or 5-6 days is not going to make a hell of a difference for this patient. But I think ultimately you are the boss on the ship, you are the captain, you decide what you want to do.
Yeah.
I just want to give my
No, I have
sense
already removed the guide catheter, withdrawn it behind. But let me show you something here. Can you see the first shot? Can you guys see the what's happening out there? Show the first shot. Yeah, this is a patient. Now the first, put it on the recycle, the first one, before this. No, before this, show the balloon mitral valve. Yeah, so this patient was a 50-year-old female with some risk factors for coronary artery disease and who had mitral stenosis. Now this, what you are seeing, a balloon getting hitched back, is after the balloon dilatation procedure. The balloon dilatation as such was not recorded. And then this patient was about to be taken out of the lab and she had sudden chest pain and became hypotensive. And lo and behold, even the monitor ECG, the leads, showed ST elevation. So quickly a 12-lead ECG was taken and she had an anterior MI with ST elevations. So thankfully the sheets were not out, and you can see the next shot. So this is about 2 weeks ago, as I was trying to tell you. The next shot, you can see there is a thrombus in the LAD. LAD is occluded. Next. So this is probably depicting what we were supposed to do here. But this is, mind you, fresh 15-minute-old thrombus. At the first diagonal bifurcation, you can see a big thrombus lodged there. There is a proximal lesion as well. And a dye hold up. The right coronary was normal. So we quickly got a guide catheter in. There you can see. And by the time we've got the guide catheter in, there is no flow down the LAD. So here we are wiring the LAD, and at the bifurcation where the diagonal took off, the wire seems to go again and again into the diagonal. So finally, a second wire, we were able to get past that acute thrombosis in the LAD diagonal bifurcation down there. Unfortunately, everything happened in such a hurry. The export that was run after this has not been filmed, but this is after having run just one pass of export. And you see the flow down there. Next. So the only issue was, after this result, cost was of course a consideration as well, because she had all the monies for a balloon mitral valvuloplasty, which as you know at our center cost just about 15,000 bucks. So far everything used for us is from our grants. So we were wary about whether to really use a stent here. It would have meant such a long stent going all the way from prox LAD going down there. Again, that diagonal where there is a little shift of the thrombus would not have flown as well. So we decided to leave it at that. And this patient really did well. Her LV wall motion, just about minor hypokinesia in the anterior territory. And she did well, and she was discharged without a stent.
Praful, what was the cause of the LAD occlusion? Was it embolization of a thrombus from the left atrium into the...
It's hard to tell. I would most likely say it was because it was this procedure, given that she was elderly and meaning the puncture was an issue, and a little bit procedure time was little more. As you know, we have a lot of fellows in training also. So it was a little more than usual mitral valvuloplasty procedure. Maybe it was heparin time having come down till the time of the balloon dilatation. So, and of course, being a mitral stenotic, we were dealing with a thrombotic milieu. The surmise was that there was an embolism of a thrombus from the left atrium somewhere, from over the balloon during dilatation, or whatever it is. But she had risk factors for coronary artery disease. She was a diabetic, and as you can see, the coronary artery disease is really there, meaning she has got some evidence of atherosclerosis in the LAD tree. So whether it was at that time she was so stressed out with the procedure that a plaque decided to rupture there, and then at the LAD diagonal bifurcation, it's hard to tell really. But we would say that given that it was aspirated so fast, and it was from a what you call post mitral valvuloplasty procedure, and people have described it. I remember one of our exams, Dr. Behra from Orissa had got us a film wherein he had a left main thrombosis in a young guy following mitral valvuloplasty procedure. So we've had such cases described elsewhere.
Yeah, I think the artery does look little irregular, and I think there is some athero disease in the LID. Looks that. I think you may be right. But I think the possibility of an embolus from the left atrium cannot be ruled out. But of course, it could be atheromatous as well.
Dr. Praful is Dr. Sripan Narayana from Vijayawada. Actually, in our center, usually we will do, even if it is a closed procedure, diabetic female above 45 years, we do angiogram because of the two reasons. Sometimes,
you would have done it. No, the plan was
acute MR. We don't know. She may has to go for surgery. That time,
I know. No, our plan is the other way around. What we do is that this patient, by the way, was to have been angioed anyway. We do the mitral valvuloplasty procedure. Say if we fail, then we add on immediately. We shoot into the coronaries and send them down.
Next issue is sometimes
of course, if you get an acute
thrombus
MR,
forms in the pigtail. Thrombus forms in the pigtail. Usually after the successful puncture, you should remove the pigtail to the descending aorta. That may be sometimes it will helpful to prevent
this patient was on the list as well for a coronary angiogram because of a risk factor. That's how we were so aware of the risk factors as well in this patient.
Sometimes even
the plan was
atrial fibrillation that will precipitate angina. Even during the procedure, if she develops
the whole issue is that what happens is that if we do a coronary angiogram before, because her presentation was clearly dyspnea and that she had significant mitral stenosis, the affordability was an issue. In any case, what happens is that the associated CABG costs, etc., it works in a reverse fashion with us. What happens is that we do an angiogram, definitely if the patient of such age is going for a mitral valve replacement. But if the patient gets a mitral valve replacement, we are within our rights, with our discretion, to use our funds for her mitral valve replacement surgery. However, if we had given her a prescription of CABG plus minus mitral valve replacement, then she would arrange her monies and would take that much longer. It's a little political issue, you know.
Any other comments from my panelists?
He's really brave to leave that vessel without stenting. That's what I wanted to say. It was really, some thrombus was still there, and then the lesion was really significant. It is definitely around 70%. I mean, you're really brave in leaving it without stenting.
Exactly. Now, the only issue is there are two reasons why we didn't stent. Number one was, of course, the finances. And number two, as what was with the case that we are proposing to beam live also, is that we have 24/7 services here. If the patient were to deteriorate, then she would have been in the lab again. You understand? And then we are in our rights to get emergency sanctions. But this particular procedure, we would not have been able to get that. The other issue, like I told you, is that you would have had to use a very long stent, number one. Number two, we would not have been able to protect that diagonal if following stenting it were to go. As of now, it's flowing very well.
How about getting some bare metal stent for her, at least for the LID?
Sir, again, she's a diabetic, and with a long stent giving to her, the bare metal long term is again an issue. In terms of the kind of a TIMI-3 flow that we've got down the artery, and we have opened this artery within a 15-20 minute period since her occlusion in the lab. So we were expecting a good flow down that artery and that she would stay open. Rethrombosis is always an issue for which she was getting monitored in so-called our best of our services.
Okay, but you know, if you remember Praful, and I think you were also trained in the time when only bare metal stents were available, and don't forget the Benny stent and the Benny stent trial, which said that a bare metal stent was better than the balloon dilatation. So I thought at least that much benefit you think she could have had. And you have got tremendous resources to raise a bare metal stent money.
Yeah, we could have raised a bare metal stent money at that point in time, but I don't know. Somehow we thought on the lines of a good aspiration result, haven't really traumatized much, got a TIMI-3 flow down the artery immediately, and that we actually watched her also in the lab for a good 15 minutes. And then we thought that abrupt closure is the only issue for which we would need to stent her. And since we were not sure whether it was a plaque rupture versus it was a neothrombosis there because of an embolization, we decided against a bare metal stent. I'm sure we were able to give her a bare metal stent. That cost 20,000.
Could you have thrombolized?
And that we would have got from our emergency sanctions.
Could you have thrombolized her?
He's asking whether you could give her thrombolysis.
We should have given her thrombolysis, you think?
Yeah, that's what one of the panelists has raised the question.
No, in a cath lab situation, sir, where we had resources to...
No, when we are not stenting, sir. When we are thinking about not stenting, could we have thrombolized? What do you think is better, sir? Thrombus aspiration versus thrombolysis? No, we are not doing the PCI versus thrombus aspiration versus thrombolysis.
Come again. You're getting me wrong. The provisional stenting was there. It's just after that result that we thought about not stenting.
Okay.
With a person with resources, would we have stopped at that point, sir?
I think, Praful,
both the cases were not an issue.
I must congratulate you for both the cases. Both the cases you have shown are very, very challenging, very stimulating.
Right,
and as you know, learning is like a coin which has two sides. You are successful, you teach. You are unsuccessful, still you teach. You do, you teach. You don't do, you still teach. So I think one lesson we have learned that that doing, not doing,
when not to intervene,
is a learning process. And we congratulate you for taking a decision which you feel is wise. And we agree with you. And what I would suggest, if you can communicate the follow-up angiogram on the young 25 years boy after say week or 10 days or 15 days, whether, as I thought this was an auto dissection, whether that got sealed off automatically, I think it will be a great thing to know about this young man. Thank you very much. And I will ask everybody to give you a big hand. Thank you very much.
We are sorry. Yeah, we are sorry to have disappointed you about not having intervened.
We are not disappointed.
Said, when not to intervene.
We are not disappointed. We have learnt to be wise. Thank you.